So substance use and incarceration, from criminalization to medicalization. I'd like to provide a theoretical framework for the lifespan transitions and recovery clinics. And for those of you who don't know, with support from the Center for Prisoner Health and Human Rights, we started the state's transitions clinic here in Rhode Island about 2.5 years ago, largely spearheaded by Sarah Martino, Jody, Brad, and others. And that clinic is tasked with providing care to medically complex people exiting the ACI, and centers the role of the community health worker who has peer-based lived experience of incarceration and also provides case management with the idea that we're addressing social determinants of health and providing medical care. And about a year later, replicating that same model, we started a recovery clinic that does much of the same thing, cares for people who have experienced both incarceration and substance use, largely opioid use disorder, and has community health workers who are tasked with addressing the, quote, social determinants of addiction, while we address the medical determinants of addiction by prescribing buprenorphine. So I have no disclosures to report. So the growth in America's prison population is intimately related to addiction and substance use. Research clearly demonstrates that people with substance use disorders are more likely to be arrested, prosecuted, and incarcerated as compared to those who don't use drugs. This same research also examines the relative reactions to low-income people and racialized minorities by the criminal justice system and concludes that poor people, especially poor people of color, receive more punitive treatment for crimes related to substance use than their more affluent community counterparts throughout criminal justice processes. One of the most comprehensive reports to date on this topic comes from the National Center on Addiction and Substance Abuse out of Columbia University. In its report entitled Behind Bars 2, Substance Abuse in America's Prison Population, Columbia's researchers analyzed data on inmates from 11 federal sources. It included data on federal prisons, state prisons, local jails. They reviewed over 650 articles and other publications, examined practices in prevention and treatment for substance use across prisons, jails, and other criminal justice facilities, and reviewed healthcare accreditation standards at these same facilities. In the end, an 87-page report was produced and published in 2010. At the time of the report, the prison and jail population in our country had reached approximately 2.3 million. 85% were substance involved. Of these, 1.5 million met the DSM criteria for substance abuse or addiction, and another approximately 500,000 did not meet the DSM criteria, but had histories of substance abuse and were under the influence of alcohol or other drugs at the time of their crime, committed their offense to get money to buy drugs, were incarcerated for an alcohol or drug law violation, or shared some combination of these characteristics. A simpler way of grasping the extent to which substance use is enmeshed with the criminal justice system is that alcohol was implicated in the incarceration of more than half of all people and illicit drugs in 3/4. However, at the time the Columbia study was conducted, only 11% of all incarcerated people with addiction received any treatment during their incarceration. Today, at least in certain parts of the country, like Rhode Island, things are very different. Medical treatment is far more robust, at least for certain types of substance use disorder. For example, in Rhode Island's Unified Prison and Jail System, the Adult Correctional Institute, treatment is offered to everyone with opioid use disorder. The system contracts with Kodak, the state's largest outpatient opioid treatment program, to offer methadone, buprenorphine, and naltrexone to patients with a DSM diagnosis of opioid use disorder. If a patient chooses to engage in treatment, they're started on one of these 3 medications in the weeks prior to their scheduled release from prison, and then given an outpatient appointment with a Kodak facility in Rhode Island. This program started in 2016, and an analysis of the impact in 2017 revealed a reduction in post-incarceration overdoses by 60% the year after implementation, as compared to the year before. The number of people needed to treat one overdose was 11. Importantly, the reduction was greatest among people with a recent history of incarceration. In addition, Rhode Island has seen the emergence of drug courts and diversion programs that place people in 90-day residential treatment programs or outpatient behavioral health programs instead of prison. As we'll discuss later on, these data demonstrate a clear benefit in people's lives, but also contribute to a complex intermingling between the carceral and medical systems. The Rhode Island data reflect a phenomenon that's happening at a national level, namely an attempt to shift drug use away from the criminal system and towards the medical system. In my talk today, I aim to review the heavily racialized legacy of these approaches to addiction and how and why it's transitioned from one of criminalization to medicalization. As a physician who provides medical and addiction care to people with a history of incarceration, I'll highlight the benefits of this shift using both the evidence and drawing from my own anecdotes from clinical practice. However, I also hope to demonstrate how medicalizing addiction can be myopic and at times reductive, and is therefore, when considered alone, an insufficient way of thinking about and caring for people with addiction. In addition, I aim to outline a theoretical framework that connects the surveillance of the prison industrial complex to that of the medical industrial complex. And through this framework, hope to build a logic model explaining why our patients refer to buprenorphine and methadone as liquid handcuffs. In the US, there's a robust literature deriving from the fields of sociology, criminal justice, and public health, demonstrating that social and political reactions to drugs have heavily depended on the social group associated with the drug. This body of literature highlights how politics, media coverage, and corporate interests have come together over the past 40+ years to create a drug social group association that has in turn determined our response as a society to drug epidemics. To illustrate this, I want to review the history of how 3 drugs came to public attention. First, crack cocaine. Second, methamphetamines, and third, opioids. The information I'm about to share with you comes from the work of Cindy Brooks Dollar, a sociologist out of UNC. The reason I'm citing her is because her work focuses on the ways in which social deviance is linked to broader social issues. For those of you unfamiliar with the area of social deviance, it's the study of the violation of cultural and social norms. This is an important area of study for criminologists and others who interrogate the criminal justice system, since anyone convicted of breaking the law is considered a, quote, social deviant. More broadly, social deviants are also people like illicit drug users who don't follow social norms and whose actions are thus disapproved of by society's eye. Let's begin with an overview of crack cocaine. The recent history of criminalization of crack cocaine began in the late 60s. Between 1968 and 1996, Congress passed 6 major anti-crime bills. The most well-known is the Anti-Drug Abuse Act of 1986, which established different imprisonment terms for possession of crack cocaine and powder cocaine. It's since been referred to as the 100-to-1 rule. Because the law, for example, established a 5-year prison sentence for the possession of 5 grams of crack cocaine and the same prison sentence for 500 grams of powder cocaine. There are many important contextual points related to the passing of the Anti-Drug Abuse Act of 1986. The first is that this and other laws regulating crack cocaine use were passed during a period when use of this drug was actually declining. There is, for example, significant emergency room and police documentation from the 1970s revealing that crack cocaine was commonly used among white, middle, and upper-class Americans, including investment brokers, professional athletes, and Hollywood stars. In response to this, legislation was passed extending health insurance coverage to drug-related treatment. However, beginning in the 1980s, as Michelle Alexander describes in her book, The New Jim Crow, African Americans were identified as the major users of the free base form of cocaine known as crack. And according to Alexander, this created a platform for the government to create laws that were specific to crack, and thus largely specific to brown and black people. In parallel, there emerged a political and media dialogue depicting crack cocaine as linked to brown and black bodies, as well as violent crime. The politicization of crack cocaine was also gendered, particularly in public health. While poor men of color were deemed dangerous and vicious, women of color were depicted as irresponsible, reliant on social welfare, and mothers to, quote, crack babies. babies who, according to the poor quality science of the time, which has since been debunked, were irreversibly damaged by in vitro exposure to crack cocaine. Sociologist Jonathan Metzl and lawyer Dorothy Roberts outline the role played by the public health and medical systems at the time by describing the example of the Medical University of South Carolina, where in 1989, a collaboration emerged between the Charleston police and prosecutors and the hospital and healthcare providers known as the, quote, interagency policy on cocaine abuse and pregnancy, end quote. This collaboration allowed for non-consensual drug testing of pregnant patients, reporting of those results to the police, and arrests of patients who tested positive on charges of child neglect or distribution of drugs to a minor. This collaboration resulted in the arrest of more than 40 patients, all but one Black women. It was halted by the NIH 5 years after its inception, and in 2001, the US Supreme Court ruled that the policy violated the women's constitutional right against warrantless searches. However, the damage had already been done. Doctors had become complicit in South Carolina and a number of other states in portraying substance use as a criminal offense, facilitating the arrest and incarceration of women of color, and importantly, solidifying the connection between the criminal justice and healthcare systems. Interestingly, the US Sentencing Commission had warned Congress of the possibility of racial disparities of this sort in the implementation of the Anti-Drug Abuse Act. But Congress did not reevaluate the legislation, making it the first time Congress had ever rejected a Sentencing Commission recommendation. Over the subsequent 2 decades, the Sentencing Commission's concerns were realized. Research since the late 1980s has consistently found that African Americans are arrested and convicted more often and given longer prison sentences for cocaine use and sales, despite the fact that their drug use is comparable to or lower than white people, depending on the source of data that you look at. For example, in the late 2000s, 76% of people incarcerated for federal drug offenses and 77% of people incarcerated for state drug offenses were Black or Latinx. This is despite the fact that in 2006, SAMHSA estimated that approximately 27 million whites had used cocaine during their lifetime, as compared to 2.6 million Blacks, and that 5.5 million whites had used crack cocaine, as compared to 1.5 million Blacks. Similarly, the evidence demonstrates that there are significantly more white people who identify as drug dealers as compared to Black people. Now let's move on to methamphetamine. Like crack cocaine, the Comprehensive Methamphetamine Control Act of 1996 was passed at a time when methamphetamine use was fluctuating, but not significantly increasing. In contrast to crack cocaine, the law enforcement efforts and media's response to methamphetamine has historically focused on poor white people. And these people were characterized not as violent threats to civilians or, quote, meth mothers, but rather as poor people living in remote post-industrial areas with little opportunity for economic progress, whose bodies had become rotted from methamphetamine use. For example, billboards showcase pictures of sickly appearing people with rotted teeth and warn people of the harms of methamphetamine use. These racialized differences between the portrayal of crack cocaine and methamphetamine use translated into the extent to which each drug was criminalized. Sentences for methamphetamine-related crimes have been significantly less than that of crack cocaine, but similar to that of powder cocaine. Finally, let's contrast the historical response to crack cocaine and methamphetamine with the socio-political reaction to opioid misuse. We're in the midst of an opioid crisis. The first major response to this crisis emerged in 2016 when former President Barack Obama signed the Comprehensive Addiction and Recovery Act into law. This bill provided funds to establish health-related support to people seeking treatment. President Obama introduced the bill with the following quote: "I've heard from too many families across the country whose lives have been shattered by this epidemic. My administration has been doing everything we can to increase access to treatment, and I'm going to continue fighting to secure the funding families desperately need to deal with this public health crisis. That's what the American people deserve." This was followed by 2 additional bills focusing on a public health approach to the opioid crisis: the 21st Century Cures Act and the Support Act. Opioid misuse is largely associated with white middle-class users, although it's not uncommon for drugs to be associated with groups who are not the most prevalent users. For example, in the case of crack cocaine. This has for the most part not been the case with opioids, though to be fair, increasingly it appears the majority of overdose deaths are among poor white people as compared to middle and upper class white people. Nevertheless, the current crisis has been framed as a white middle class public health issue, with media coverage depicting opioid users as white women and young white people, quote, with bright futures, in need of sympathetic responses, including addiction-related treatments, harm reduction strategies, and public education. This affirms the theory that emerged with crack cocaine and methamphetamine, which is that the race and class of the drug user, and I should mention often supplier, in this case doctors and pharmaceutical companies, explains the heavily medicalized response to the opioid crisis, and in turn, the extent to which use and misuse are criminalized. Viewing the crack cocaine, methamphetamine, and opioid crises through a socio-political lens helps us understand how and where they fall on the criminalization-medicalization spectrum. There's no question that medicalization has conferred a number of benefits. First, medicalization has provided hundreds of millions of dollars in support to research and treatment. The case example discussed earlier from Rhode Island was possible because of an influx of federal and state funding. Also, as a result of this funding, there are now 3 FDA-approved drugs for the treatment of opioid use disorder. Second, medicalization has promoted a shift toward conceptualizing substance use disorders as chronic diseases. For example, we often teach medical students and residents that opioid use disorder is a chronic, remitting, and relapsing disease, and draw analogies between prescribing principles for buprenorphine and insulin. When someone is diagnosed with diabetes and started on insulin, we don't expect a linear trajectory in which their diabetes control only improves over time. Rather, we more often see fluctuating levels of sugar in the blood due to incomplete adherence to a diabetic diet and diabetes medications, among other reasons. Similarly, if their sugars spike due to stress or celebratory eating around the holidays, we don't say you aren't following the plan and stop the insulin. There's no reason why a person's opioid use disorder shouldn't fluctuate in the same way. The value of this paradigm is that it helps medical providers who may otherwise find it difficult to overcome the stigma around treating people who use drugs to conceptualize their patients and their own role in their patients' treatment in different ways. In other words, it opens more possibilities for interactions between patients and providers without stigma interfering in that therapeutic relationship. However, while there are important benefits to conceptualizing substance use as a medical issue, including the fact that it's helped to move people from prison to the community, it remains a profoundly limited and at times problematic conceptual framework. Both criminalization and medicalization share a focus on the individual as the problem. For example, criminalization narrows attention to punishment and deterrence of the offending behavior, and medicalization narrows attention to symptoms and medical treatment. Neither encourages an examination of the underlying societal issues that drive drug crises, nor the structural factors that can support decreased use. In fact, both drug, quote, wars and drug, quote, epidemics divert public attention away from systemic inequalities by focusing on discrete groups of people who manifest certain attributes or behaviors. In this way, individual responsibility is the cornerstone of both the criminalization and medicalization models. This extends even to sellers. The moral depravity of fentanyl manufacturers and dealers are the focus in the public discourse, as opposed to interrogating the structural forces in the lives of both sellers and users. Another limitation of both the criminalization and medicalization of people who use substances is the misconceptions that have been generated about the lives of people who use certain types of drugs. Lost in these myopic and reductive constructs is the fact that while the number of fatal opioid overdoses increased from 16,000 to 52,000 per year between 1999 and 2015, cocaine was the largest contributor to overdose deaths among Black men and women. Cocaine-related deaths peaked between 2004 to 2007, then declined slightly through 2011, and have since been increasing steadily. In 2018, the year we have most recent data from, death from cocaine now surpasses deaths from prescription opioids and heroin. The fact that there has not been a similar outcry to understand cocaine use as a chronic disease, needing medical attention and research dollars, is deeply rooted in the legacy of criminalizing those who use crack cocaine, and thus racism. Finally, and most importantly, there's a thread of surveillance that's carried over from criminalization to medicalization. On the ground, in our everyday practice of addiction medicine, what we've found is that there's a culture of surveillance that's carried over from the carceral system into the medical treatment of opioid use disorder. For example, people can only receive methadone from SAMHSA-approved outpatient treatment programs, where the medication is dispensed on site, requiring that patients present to the clinic daily. After long periods of adherence and abstinence from all other drugs, patients may qualify for take-home doses of methadone. However, this is heavily regulated and difficult for patients to achieve. As Philippe Bourgeois describes in his ethnographic study of patients attending a methadone clinic, this treatment can be profoundly life-limiting. The requirement of daily attendance makes it difficult for people to hold jobs, travel, and otherwise maintain average lives. In addition, there's a sense of loss of autonomy, similar to that experienced by people living behind bars. Here's an illuminating excerpt of a conversation between the ethnographers and patients from Bourgeois' work. Sid, look what they did to you last month. They cut you way down, made you real sick for a while. Harry, that was for a whole week just for drinking. Max, at 80 milligrams? You don't know how wrong that is. Sid, they got complete control of your fucking life. Max, that stuff is strong, man. It's stronger than heroin. Sid, that fucking bitch. That's why I'd never get on maintenance again. It's like being in prison. I can't stand that. They got you scared all the time. They threaten you. Do this and do that. And they fuck with you all the time. You know, fucking following the rules. And then when they get a little hair up their ass about something, they're gonna cut you down. We're gonna cut you off. That shit is life and death, man. Max, they just did it to me, man. They've been dropping me in just a few days. The last few mornings, I've been feeling really bad. Philippe, what's your dose? How many milligrams are you on? Max, they don't tell you how much they're giving you. By the way, this is from the early 2000s. But this guy I know at the clinic, he told me he started me at 40. Then I asked for 3 raises, 3 days in a row. So I must have been at 50, between 50 and 60. Now they're dropping me down and it's been a week and a half, and the last 3 days I could feel the difference, a lot. I wake up at about 3, and I lay there, just waiting till 7 or 8. I could hardly walk this morning. Harry, yeah. That could kill a person. Sorry, I can't fully read the end of that slide there. On the ground, there's also an overarching culture of surveillance and discipline in the way in which buprenorphine is prescribed in the United States. Although buprenorphine can be prescribed in the primary care setting, unlike the way in which we care for people with diabetes on insulin, for patients on buprenorphine, guidelines recommend they be seen weekly, initially, usually in conjunction with urine toxicology testing, and that subsequent intervals be determined by the results of urine toxicology testing, in addition to other factors. Buprenorphine can be legally prescribed for up to 6 months. However, providers rarely prescribe more than 1 month at a time. As such, individuals remain controlled by the medical apparatus. In order to arrive at a deeper understanding of the implications of surveillance in the medical system, it's helpful to build a theoretical framework. To do this, we'll draw on the work of 2 philosophers. Michel Foucault was a French philosopher who wrote extensively about American and French prisons. He used the architectural structure known as the Panopticon to describe the impact of surveillance on prisoners. The Panopticon is a structure that was originally designed by Jeremy Bentham. It's a watchtower that's centrally located on a prison campus. In the watchtower, there's a single correctional officer peering out into the prison cells of the inmates, which are lined circumferentially around the periphery. There are hundreds of cells with people inside them, and just one correctional officer. Yet Foucault describes how the prisoners remain constantly on edge, in a perpetual state of stress, because they know that the correctional officer could peer into their cell at any time. This contributes to the high stress levels and profound sense of loss of control that prisoners feel on a daily basis. This same form of surveillance exists in healthcare, in part because the person with a substance use disorder spends most of their time transitioning between the prison, the street or shelter, and the hospital. For example, consider the setup of a typical nursing station in the hospital, where the station is located centrally with the patient's rooms along the periphery. There are additional similarities between the prison and hospital, like the thickness of the doors and the ways in which the latch sounds as the doors in both locations close. In addition, patients and prisoners don't have control over the structure of their day. When they're woken up in the morning or in the middle of the night, when meals come, when they have access to their healthcare provider, they're often not allowed to leave their room, especially if they have a history of substance use, and can be subjected to random searches if there's concern that drugs have been brought in. There's also a very palpable power dynamic in both locations, with the correctional officer and the prisoner in one, and the doctor and nurse and the patient in the other. It's therefore not surprising that people with a history of both substance use and incarceration tend to leave hospitals, quote, against medical advice, at higher rates than the general population, despite often needing life-saving treatment. When asked about why, patients cite feelings of trauma and often even say that the hospital reminds them of prison. This concept extends to the outpatient setting, and Frantz Fanon demonstrates this in some of his work. Frantz Fanon, a Black psychiatrist born in Martinique, who worked in Algeria during the French-Algerian War, cared for Algerians under French colonial rule. And what he found was that French medical providers expected the bodies of Algerian patients to, quote, be more talkative, end quote, than the patient's own descriptions of their conditions. The French doctors, operating as part of an oppressive colonizing regime, inherently distrusted their Algerian patients and therefore valued objective testing, such as, for example, a urine toxicology, over their patients' subjective histories. In response, the Algerian patients experienced the physician-patient relationship as violent. And though they may have benefited from their physician services at times, the true potential of that relationship could not be reached. With this theoretical framework in mind, we've sought to build programs for people with histories of incarceration and substance use that center at the margins. In doing this, we're constrained by the guidelines and prevailing culture of medicalization, which tends to dictate care in our current system. However, we've sought to interrogate the areas where guidelines are based on expert advice, which is often difficult to disentangle from hegemony, rather than definitive evidence. The use of urine toxicology in the care of patients with substance use disorders is an example. The literature exploring whether urine toxicology testing improves patient outcomes in substance use disorder treatment is limited. Yet expert panels cite extensive clinical experience in support of improved patient outcomes with urine toxicology testing in addiction treatment. Most studies evaluating the utility of urine toxicology testing are in the setting of chronic pain patients and often specifically exclude patients with substance use disorder. In fact, 2 systematic reviews on the efficacy and role of urine toxicology testing in opioid use disorder suggest there's actually very little evidence on the effectiveness and impact of urine toxicology testing frequency on patient or community health outcomes. The most recent of these studies is featured in this slide. Further complicating the question of utility is the fact that most providers don't have a thorough understanding of urine toxicology testing methodology and what information can and can't be gained from the test. Many providers, unfortunately, cannot proficiently interpret urine toxicology testing and don't understand its limitations. Inaccurate interpretation of the urine toxicology test, such as false positives or false negatives, can have adverse impacts on treatment of opioid use disorder. Potential negative consequences include a breakdown in the relationship between the patient and provider, inappropriate adjustment of the treatment plan, or lead to inappropriate punitive actions against patients, which in some cases can cause patients to abandon treatment altogether. In our recovery clinic, we've developed a patient-centered practice. We don't penalize patients for positive urine toxicologies, missing appointments, or tardiness. Prior to April 2019, we ordered a urine toxicology test at almost every patient visit. However, in early 2019, upon release of a new ASAM guideline recommending that urine toxicology only be ordered if the results might impact treatment, we began significantly curtailing our use of this test. In fact, we now almost never order a urine toxicology test. In addition, we approach caring for our patients via a structural lens. For example, we utilize a dedicated community health worker who provides peer support and case management, and a care coordinator who also focuses on the social aspects of the patient's addiction and has a clinic-provided cell phone that the patients can use to contact them via text message or call. These methods provide us with an invaluable flexibility in the treatment of our patients, allowing us to work with them rather than dictating how their care will be delivered. We often prescribe patients buprenorphine for 3 to 6 months at a time and heavily rely on text message communication, understanding that our patients often don't have minutes or reliable access to a phone. Our clinic has a relatively high overall retention rate. Studies conducted on MAT retention rates show varied results, ranging from 38% to 100% retention. When comparing our retention rates before and after the ASAM policy change in April of 2019, we saw an increase in overall retention. Our findings suggest that the philosophy of schedule flexibility, low threshold access to staff, and patient-specific urine drug screening promotes an open, honest environment that the patients consistently seek out and participate in. The major limitation of our data is that it derives from one clinic. However, with recent modifications to the SAMHSA and DEA guidelines around prescribing and dispensing of controlled substances, a number of clinics have adopted less rigid practices in an effort to slow the transmission of COVID-19. As a next step, we hope to assess patient and provider experiences of buprenorphine treatment pre and during COVID-19 and look at lifespan-wide outcomes as they relate to the frequency of urine toxicology testing. Thanks for listening. Happy to field any questions.
Well, bravo. That was really an outstanding tour of drug policy and patient management. And I wonder, you know, I saw a patient this week, and he's doing well on opioid use, medication for opioid use disorder, and which I'm prescribing, and I don't have any concerns about diversion or lack of adherence. And I just said, well, you know, I hadn't checked a urine tox in a while, and so I just checked it just as a random, you're coming in. And I had struggled for in various ways to get this individual into some counseling around his addiction, and he seemed to be doing well, and there was some structural obstacles. And so anyhow, it didn't do that, and there were a lot of other medical complications we were focusing on. And I was a little surprised by when the toxicology result came back positive for fentanyl. And so surprised that I actually confirmed it. And in fact, it did confirm. And that led to a discussion with the patient that was very positive. And, initially there was embarrassment. There was, a description of the labs. And this is a patient who also has chronic pain issues. And we've had discussions in the past about, at one end of the spectrum is chronic pain on opiates, and the other end is opioid use disorder. And in my experience, most people are somewhere in between. And anyhow, the net result was we're going to try and get him some more counseling. And in that way, it sort of opened the door to more discussion between him and I. And it was clearly, not a situation that was punitive. And I think it's going to result in him being more comfortable in talking about, urges and cravings and triggers. And so I think in that sense, it's a positive way. On so many other situations, I hear about all these horrible results of a positive tox screen. Oh, that's it. Now you're going to have to be no more take homes for you, and basically a punishment and an adversarial response. And I can see how that. The problem is really what you do with the data, not so much that you're gathering the data. But what are your thoughts on that?
Yeah, those are really good points. And in fact, my wife, Catherine, who practices in these same programs, and I have these discussions all the time, along with the members of our clinic. Because we're an interdisciplinary team, we have a number of community health workers, peer recovery specialists, most of whom have a history of opioid use disorder and have spent time on buprenorphine or methadone, and who often talk about their own experience on those medications. And almost inevitably, the people who we hired tell us that they, for a period of time, diverted their buprenorphine, or were using cocaine at the same time, or sought out clinics where urine toxicology testing wasn't done. And I think a lot of people, and I think it's those anecdotes, plus the fact that for a lot of providers, as you mentioned, the urine toxicology test can feel like a really useful tool and an introduction to important conversations, that we continue to use it regularly. And my point as part of this talk isn't that we shouldn't use the urine toxicology test, but rather that I'd like us to interrogate the ways in which we use it, and the evidence for its use. And so starting with number 2, what I wanted to make clear is that we don't have nearly enough data on how to appropriately use urine toxicology testing. The data we have are equivocal, and so there's nothing definitive out there. And yet we see widespread use of it. And as you mentioned, Jody, if we're seeing widespread use of it, and we know that then many providers are sort of misusing it, or perhaps not messaging around it in a way that's appropriate, then maybe the task is to re-educate providers on how to have these discussions. And yet, starting from that place is really challenging, because we know it's so hard to change provider behavior. And so I think my argument is that we should start from a place of interrogating why we use it to begin with, and sort of redefining the purpose of that test. And in this case, I think that because there's a lack of evidence, that should mean that rather than starting with the urine toxicology test as the standard, legally for buprenorphine, you have to check it in the beginning, and then there are no legal requirements after that. For methadone, I think it's 6 times a year or 8 times a year at an OTP. But my argument is, why don't we start on the other end of the spectrum, which is where we would usually start when we're lacking evidence, which is, it's a tool. Let's really use our discretion when we use it, but the standard should be do not use it unless it's legally prescribed. And I think what happens then is that you get a natural culture shift, where if, right now we often say, and addiction experts say, like, hey, I use this because it invites discussion, it opens up conversation. But might taking it away, pretend we're practicing in a developing country and we don't have it as a resource, might taking it away move us to act and operate in clinic in different ways? Might we decide to use different language? Might we decide to fund different resources, like a community health worker who can perhaps establish a stronger relationship? And so a very practical example from our clinic is that we've had a number of patients, but I'll give an example of one patient. We had one patient who had really had a rough time, but was starting to do really well. And after about a month of weekly checks, they had some things coming up in their life, and I decided I was going to give them a 3-month prescription of buprenorphine. And so I did. She came back 3 months later. We hadn't really touched base with her in those moments. She came back 3 months later and was having hallucinations and delusions that were cocaine induced. She had been using cocaine daily. And she sat down, and we sat down and we talked about it. And she explained that this was happening. and said, I really wish you hadn't given me a 3-month supply. I want to continue coming back weekly because that's what's helpful for me. So the question then is, how do we get to a point where we build trust in our patients where they can say that to us rather than us having to say that to them? And I would argue that in our case, I don't think we're a perfect model by any means, but I'd argue that in our case, having text message access, being liberal to begin with, so showing trust from the get-go, having a community health worker, and having a program coordinator who sits down with people to do housing applications, help with other sources of income, etc., builds that trust and moves our patients to tell us when they need the help. And of course, we never want them to get to a point where they overdose and die. But I don't think that happens if we flip the paradigm, because flipping the paradigm again requires that we change certain structural things about our practice. I hope that makes sense, and I'm sorry that was long-winded.
That's great. I don't want to monopolize the question, so, and I don't know how to see who has a question or not, so I guess just jump in.
If you want, you can just ask a question, or you can ask it in chat, and I'll monitor that. Either way.
I have a question for Dr. Vanjani.
Thanks so much.
Great. Thanks so much for your presentation. That was terrific. I'm a new pilot awardee, and my research will be looking at buprenorphine adherence using data from the Rhode Island Prescription Drug Monitoring Program. And I'm particularly interested in prescribed controlled substance polypharmacy. I'm a professor at the College of Pharmacy. I've worked at Butler Hospital for 15 plus years, with patients, and have an interest in understanding how concurrently used prescribed controlled substances may influence adherence, and now actually interested in as well in looking at the days supplied and quantity dispensed and seeing if that may have a role in adherence patterns as well. And I just also want to thank you as well for your background and the way that sort of you helped me appreciate how to approach terminology and understanding some of the deeper constructs of adherence that'll be really useful to my project. So just, I guess, a lot of appreciation, but if my particular question would be if you had any insights about managed care policies and insurance barriers to quantities that are greater than a month at a time.
Thanks a lot. And I thought your question was going to focus on polysubstance use, but it sounds like what you're asking is more around sort of policies dictating the length of time we can prescribe buprenorphine. Is that correct? And
well, I'd be interested in your perspective on both. I think the latter is more of a practical issue for my research to understand barriers to accessing larger supplies of medication. But certainly if you have any insights about benzodiazepine use and perhaps other medications that may, be an indicator of, a patient that might be sort of in a different, or might need to be considered differently with respect to adherence patterns.
Yeah, I think I understand. I think one of the easiest examples is concomitant cocaine use. We know from literature initially published by Trinazzo Cunningham, and then many others since then, starting in the mid-2000s, that people who get onto buprenorphine, and even earlier than that, people who get onto methadone, tend to increase their use of cocaine. That's well established, and rates vary, but we think up to 50% of people who get on maintenance treatment use cocaine. And so one question that I think we think about often, especially with regard to the urine toxicology test, is what to do around that. And a lot of providers take an evidence-based approach of sort of like providing rewards for patients stopping their cocaine use. And so whether those are in the form of money or in-kind gifts, or in the case of buprenorphine or methadone, spreading out those visits. And so a lot of providers will say like, hey, there was cocaine in your urine, and will very successfully get people to stop using cocaine by saying like, I'll give you a longer prescription if I don't see cocaine the next time around. And obviously there's more that goes into that. That sounds very rigid, but there's more that goes into those discussions. And I think that we as providers do what we have, what is available to us. Like we call on resources that are available to us, and we're very much in control of a length of a prescription and length of follow-up. We're more in control of those two things than really anything else. And we're armed by hegemony, or in this case, like the prevailing culture, which says that's the right thing to do. I think that anecdotally, a lot of people start using other substances because of freed up time once they get on medications for opioid use disorder. And again, my sense is that when time is freed up, and I'm sure there are other factors that play into it, taking the approach of like contingency management is that's one way of going about it. But certainly what would be more effective is considering again like the structures involved. And so in this case, time is freed up, and what does that say about our society and the research we can do to figure out how to why that time is freed up and how to fill it. And so I think considering research around like social security claims and income and other like social and welfare programs that help support people who are newly in recovery are important, and that this approach of using our power as physicians is only going to get us so far. Especially as we've struck out over and over again in finding medications for the treatment of things like cocaine, benzodiazepines, and most importantly, alcohol. We use naltrexone, Topamax off-label, acamprosate regularly, but most of us know that they're not particularly effective.
Yeah,
I hope that answers at least a part of your question, and I'm sorry if it didn't.
Yeah, I mean, my question was really just a veiled thank you for a terrific presentation. Just wanted to chime in.
I'll make an introduction by email too later to both of you, so that way you can communicate offline.
Terrific, thank you.
That's Gail, by the way.
So,
Any more? Oh,
any other questions?
Hi, can you hear me?
Yeah.
Hi, Marvin.
Hi, Gail. So, yeah, here, I'm Mamun here. So, I'm working with polysubstance use project. And I'm analyzing, basically I'm developing data mining methods to understand polysubstance use patterns among the fatal overdose deaths. So your presentation actually confirms some of my results that I see in the toxicology reports from the data from Connecticut. So basically I'm analyzing data from 2012 to 2018, which are like toxicology data. And I have so basically binary variables for each substances. And I'm trying to understand what patterns I see. And it is interesting that, in practice, oh, by the way, your presentation was really great. So, I literally, you literally took us to the journey of these three particular polysubstance use of these drugs. So, yeah, coming back to the confirmation of the results that I have. So, when I analyze the data, I can see. I can see that what you are saying. So I can see that benzodiazepines are oftenly found in toxicology report with methadone and heroin. And I'm not sure whether whether we have time here or not, but I actually wanted to show you these are the combinations. Can you see my screen?
Yes, I can see it.
Yeah, so these are the combinations. So these are the combinations like buprenorphine and benzodiazepines, and these are the number of years that like we observed, basically observed in the toxicology report. This is the population, and this is the prevalence, and this is the age, like this is the demography. So uh, we can see here that the benzodiazepines are commonly found with heroin and methadone. So these combination means these combination means that the person who actually died because of these overdose, these combinations were found in their toxicology report. So we can see that benzodiazepines are quite commonly used with methadone. And but the problem with this data that we cannot really say that whether they are concurrent users or concomitant users or not. And also you can see the hierarchy of these use. So fentanyl, heroin, cocaine, and methadone, and it was seen consistently for 3 years, and these were the prevalence. So yeah, so your presentation actually confirms some of these uses, and we see these complex polysubstance pattern in the toxicology report of the fatal overdose.
Yeah, and that's a great point, and I think that's also an interesting point, just because that is an issue that's so often raised in clinical practice. In particular, it's a really important point, and as we know, the FDA changed its guidance around its language around co-prescribing of benzodiazepines and opioids recently, and we have a little bit more leeway now in terms of prescribing benzodiazepines to individuals on methadone, buprenorphine, full agonist opioids in general. But I will say that my understanding of the data is that the percentages are still relatively small, and I think what I worry about from a clinical standpoint, and again, this is based on anecdote, is that a lot of people are driven to benzodiazepine being used by a number of sort of complicated factors, but one of those is anxiety. Again, when time is freed up, this is an overly simplified way of talking about this, but when you're in recovery, time is freed up. There's a lot more mental space to put toward feeling overwhelmed and anxious about the world around us. And I think a really important issue then becomes one of access. So, I think we're at Lifespan. I think we're in a culture at the moment where we're being a lot more open about systemic racism. And so I feel a little bit more comfortable saying this today than I would have 2.5 weeks ago. But, let's take the example of Lifespan psychiatry group, right? It is very difficult to get someone into care. So first we know that if you force someone into behavioral health care early on in their recovery, that can actually be harmful. There's no question about that. But once someone is ready to engage in care, it can be really difficult to get them into care. And we've created this two-tiered system of community mental health and private mental health. It's very easy for us at Lifespan to say this person seems like they belong in community mental health if they have a history of substance use or incarceration or whatever else. But we all know that the community mental health agencies in Lifespan in Rhode Island are overwhelmed and have a high turnover of staff for a variety of reasons related to salary and otherwise. And so again, what we're seeing is that community mental health agencies, which fill a really important gap, are a very good example of structural racism at work. Community mental health embodies they are structurally racist. And so then Lifespan psychiatry, or Lifespan in general, is structurally racist by definition too, because they're saying if you're not a perfect patient who can adhere to all their appointments, there's this policy if you miss 3 and you're out, then you belong in community mental health. And so that leaves people in this middle zone. And I think so many of our patients have difficulty accessing care for that reason. And so I think a lot of this conversation around benzodiazepine use and opioids has its roots in structural inequity by class and race.
Yeah, great for explaining that. I was just, when I found these combinations, I was just trying to think, how do I connect them with the with the real life usage, because it doesn't say any concurrent use, but I think your presentation, also explanation, gives more sense. Okay, this is what we see at fatal overdoses, but there are a lot of stories they are going on behind the scene. But I think I do agree with you that using these urine toxicology reports are like, we need to be very careful when we are making assumptions from there.
So we just have a few minutes left. Unless there's any burning questions, I think I will just make a few points. I think, first of all, this has been a really great talk and discussion, and a lot of food for thought, including the last comment about structural racism and community versus private mental health. Another key point that you made was the high rate of stimulant overdoses. And when we described the COBRI on opioid use and overdose, opioids and overdose, in hindsight, we put up that name thinking about opiate overdose, but in hindsight, we realized we had captured that extra territory, which we really need to explore. And I think it's high time we have somebody to put together a review article on stimulant overdoses and really kind of drill down on that. So anybody who's interested, let me know. I've kind of talked to Gail last week, and Gail said, well, Jody, we got some things to do about the COBRI. We got to, catch up on things. And I've been pretty much buried at the Miriam Hospital under a mountain of COVID patients. And I said, oh, that's great, Gail. What's the COBRI again? That was supposed to be a joke. But I think it's, the whole world has been turned upside down. Everything's been shaken up. And now it feels like it's starting to settle a little bit in some places. But I think there's an incredible opportunity, and in particular around opioids. I just heard this morning that we are on track to have the highest number of overdose deaths in Rhode Island ever, based on the first few months of this year. So this has not been a good positive effect on overdose deaths. And yet I think there's been some positive changes, like allowing telephone induction of buprenorphine and some relaxation on methadone use. So I think, we really need to double down on our efforts to figure out how to address these problems. And I think perhaps in the interest of time, I will just leave it at that. But thank you all for participating, and Gail, thanks for organizing.
Welcome.
And Rahul,
Thank you,
thanks
everybody.
for an excellent talk.